Hey, welcome everyone. Today we are going to discuss in detail regarding renal cell carcinoma, and we are going to capture all the high yield points regarding renal cell carcinoma types, pathogenesis, and morphological features, clinical features, diagnosis, and more stuff. So please stay till the end of the video. We're going to have lots of learning. So, renal cell carcinoma, called as hypernephroma, gravis tumor, renal adenocarcinoma. Males are having predominance with almost 2.5 to 3 times more compared to that of females. And there are various predisposing factors that are seen in renal cell carcinoma. The important one include tuberous sclerosis. Smoking is an important factor. ADPKD, autosomal dominant polycystic kidney disease, exposure to some chemicals. These are some known associates of renal cell carcinoma. Majority of the tumors are sporadic. VHL gene mutation is seen in many of them. Familial cases also do exist, and some of the familial syndromes associated with RCC are von Hippel-Lindau syndrome with homozygous VHL gene mutation causing CNS tumor, angioblastoma, and renal cell carcinoma. Hereditary clear cell carcinoma. Here also there is a homozygous VHL gene mutation, but without any CNS tumor, only clear cell RCCs are being present. Hereditary papillary RCC. These are associated with c-Met proto-oncogene. So these are some important stuff that you need to remember. Coming to the gross features, it arises commonly from the upper bone cortex. Proximal convoluted tubule PCT is the common size. Size is around 3 to 15 centimeter. That is the general size of the range of the tumor size. And color is solid yellowish white, and it may appear yellowish due to abundant fat content. Cystic changes with areas of necrosis are also seen. And it is also common for the tumor to involve the inferior vena cava. It can metastasize to right chamber of heart, and also it can impinge on left testicular vein, and sometimes it can present as varicose. So here in the image, you can see a large chunk of the tumor with areas of necrosis, hemorrhage, some variegated appearances are there, and a small portion of normal kidney is seen, but majority of the kidney parenchyma is occupied by the tumor. So clear cell carcinoma accounts for 70 to 80% of all the cancers. Papillary cell carcinoma 10%, and c-Met oncogene, as we have discussed, that is the common one. Chromophobe 5%, and arises from intercalated duct. And there is another one, that is collecting duct carcinoma, that is also seen in renal cell carcinoma. And here you can see the clear cell type of RCC, and here you can see that cells are arranged in nest. Multiple nests are there, which are separated by some thin septae are there. Cells are having abundant clear cytoplasm owing to the abundant glycogen content. And papillary RCC, you can see the papillae, multiple papillae with some kind of a dark structure are there. And these dark structure are nothing but dystrophic calcification psammoma bodies. Now it is worth remembering that many of the papillary carcinomas, including papillary carcinoma of thyroid, serous papillary adenocarcinoma of ovary, they all have psammoma bodies. So here what we see is large number of papillae, and papillae are having some fibrovascular core are there in many of the papillae, thin fibrovascular core, and there are some psammoma bodies that are additionally present. Chromophobe renal cell carcinoma. Here again there are clusters of cells, and they are having clear to predominantly pale eosinophilic cytoplasm is there. And the important thing that distinguishes it from clear cell carcinoma is the pale eosinophilic cytoplasm, plus there is a perinuclear halo as distinctly seen in many of the cells. And these carcinomas, chromophobe carcinomas, also beautifully stained for Halley's colloidal iron, which decorates the acid mucin. As in the inset, you are seeing that there are some bluish granules, that positivity is there. So that is Halley's colloidal iron positivity. The clinical features of RCC are costovertebral pain, palpable mass, hematuria, and costovertebral pain. These are the two important features. Palpable mass also may be seen in many of the cases. Metastasis to different areas, lungs, bones are also seen. That is also a common feature. Apart from these classical features, there are some paraneoplastic syndromes that are also elaborated in RCC due to production of various substances like PTH, which causes hypercalcemia. Erythropoietin production can lead to polycythemia. There can be some FSH-LH elaboration may be seen. Cushing syndrome may be seen sometimes due to ACTH production. IL-5 excess production may lead to eosinophilia. Leukemoid reaction may be seen, and even accessory secondary amyloidosis may also be seen in renal cell carcinoma. And left testicular vein metastasis and varicocele of the left testis is also a common clinical feature. Now, how do you treat? The treatment includes resection, that is the common mode, partial or radical nephrectomy. Chemotherapy and radiation are not much effective conventionally, but now promising results are seen with adjuvant neotherapy, immunotherapy, and chemotherapy like interferon, cytokine, IL-2, and some other specific immunotherapy are there, which targets the tumor cell and are having a good result. Now let's have a summary. RCC can be sporadic or familial VHL gene mutation, that is the important gene to be mutation remembered, and in the clear cell, and MET oncogene in the papillary carcinoma. Common subtypes are clear cell papillary chromophobe, though there is a urothelial carcinoma that just recapitulates that of the lower urinary tract carcinoma, that is the transitional cell carcinoma. Urothelial carcinoma is seen in renal pelvis as well. Common signs and symptoms of renal cell carcinoma include costovertebral pain, palpable mass, hematuria. Treatment involves resection conventionally, and chemoradiation and immunotherapy may also be tried for better results. So, thank you and happy learning.
Thank you for watching the video. Please subscribe to the channel, hit the bell icon, and follow in our different groups. And please stay tuned for the next video. See you in the next video. Thank you.